So welcome to the Greater St. Louis MGMA April 2022 webinar. We are so glad everybody is here. Before we get started, we have a couple housekeeping items. One, all webinar attendees are in a listen-only mode. We will be using the chat feature to take any questions, so feel free to submit your questions at any time during the presentation by clicking the chat button at the bottom of your screen. Today's webinar is recorded, and a copy of the recording and any available slides will be posted on our website under the online education section of your member center. And thank you for joining us for the April 2022 webinar, Tips for Reducing Liability Exposure in the Physician Office, presented by Diane Rowan and Jeff Hebenstreet. I'm now going to turn the controls over to our presenters.
Well, welcome everybody. It's one of those things of, is it good morning or good afternoon? So in any event, we were talking about the weather. Hopefully we'll get through this without power outages, hail, and tornadoes. But so I'm Diane Robin. I am a healthcare attorney with Sandberg, Phoenix, and Von Gontard. I know many of you that are on the line. I've been representing healthcare providers for 25 years now, doing medical malpractice defense work and also general risk, transactional, and regulatory compliance type work. And with me is Jeff Hebenstreet with Keen Insurance. He's a healthcare practice consultant with them. And Jeff and I have worked together for the past 10, 12 years or so, meeting through an MGMA annual conference. So we were networking at a table and chit-chatting, and we've enjoyed a great relationship for the past 12 years or so as trusted advisors to one another and referrals. So when we were asked to do this presentation, we sat down and kind of started talking about it. And as we like to do, discussing, what's the latest risks that we see within physician offices or so. And, everybody's been focusing on COVID and what's been going on. And we kind of took it a step bigger than that and said, with everyone emerging, hopefully, find some wood, emerging out of COVID here in the next, over this next year in 2022, how is that impacting physician practices as far as potential liability risks, and what can you do to try to mitigate against those potential risks? So today, what we plan to kind of go over is Jeff's going to give you a little bit of an overview of what's going on within the insurance market. We learn from history, which is always a great thing, of what's been going on for the past 20 years or so. And what's going on with the market now? There's been a lot of changes with everything that's going on in the virtualization of our lives. So kind of where we are and where we're going to be going. And then I'm going to talk a little bit about COVID-19 and how that has kind of impacted the way that healthcare is delivered and what our quote new norm end quote is going to end up being. Give you some tips and practices on trying to reduce potential liability, and then talk a little bit about telemedicine, not in tremendous detail, but just some things to really think about. As we're going through this, feel free to put some questions in the chat. We're going to try to monitor the chat function for the two of us, and we'll get a chance, we'll incorporate those questions into our presentation. And then obviously talk a little bit about dealing with the stress of all this, because as we know, it takes a village to handle all of these things. So with that, I will turn things over to Jeff.
Front and center. It may come as a big surprise to most of you, but Diane and I actually were talking about food when we met. So just to give you a heads up there. So as Diane said, I'm going to talk a little bit about medical malpractice, where we've been, where we're going, kind of what our thoughts are as one of the larger brokers, certainly in Missouri, but amongst the largest in the nation as well. Trends in the past, where we've been over the last several years, and kind of where we're going. So as Diane said, I would appreciate any comments or chat in the chat function to make this more than just a one-sided meeting, and would welcome your comments. So wanted to talk a little bit about cycles. You never know who your audience is in a webinar, but I know there are quite a few of us gray hairs on this, but there's a lot of younger folks too. And some of those folks may not have experienced the late 90s, early 2000s that the rest of us did, and what an absolute crisis. And I don't think that's an over exaggeration to say that we were in a crisis in the late 90s and early 2000s. I recall, and I made some notes about the experiences that I had as a practice consultant at that time, that the economy wasn't in a great place. We were in a very litigious environment in Missouri without a lot of tort reform or tort protection for our physicians. And this is a bit of a newer term, but I think it applies also to the times we were in back then of social inflation. And again, a newer term, and it basically represents where society feels we are in the context of lawsuits, and how patients that have suffered in malpractice claims damage, and how they should be compensated for that damage. So while it's kind of an undefinable term, it's a real impact and effect on what we do. So, again, like I mentioned, the early 90s and 2000s, I think what we experienced were very few companies that were available in the marketplace. And kind of like any industry, and the lack of competition, in the lack of choices, you have a lack of competition, and that leads to higher rates and stricter underwriting guidelines that we did suffer through, at that time. I go back to that time, and I guess what really sticks out for me were the OBGYNs during that period. Had several clients that were paying upwards of $120,000 a year in premium for the standard limits, and these were physicians without claims, and they were physicians that were in their scope of training. But this is what the market was yielding at the time when all these things were applied.
And a lot of that, gets impacted by, I do a lot of medical malpractice defense work, and those OB, wrong birth asphyxia cases, where you've got brain damaged baby cases, they're expensive. I mean, they drive the value of those cases, and the plaintiff's lawyers can trump up damages where you're looking at a $50-60 million claim.
Oh, certainly high emotions, as you would imagine, when a child's life is lost. So fortunately, we did transition into what we term as a soft market. 2004 would have been maybe a little bit early to say that, but I think this is where we started to see new carriers and new statutes in Missouri's insurance code being applied to the startup companies that were coming in at those times. And we started to see more competition. We saw rates starting to inch downwards as that competition came in. And that also coincides with, I believe it was 2005, when Missouri's tort reform, first real meaningful tort reform, came into effect. And I guess there was a sense of protection amongst the carriers that this could be a more financially viable venue to provide coverage in, and that they could support actuarial soundness with the rates that they were offering. So, and finally, to that point, relaxed underwriting. I always think back to Botox. Botox was kind of a newer treatment, and I remember most of the time it was hard to get a carrier to approve it unless your training was in plastic surgery. But over the last 15 years or so, we've seen that greatly relax to a point of, I've had a pediatrician apply for Botox coverage, and was approved. So I kind of talked about the extent, I'd like to talk about the extended soft market, kind of where we are and where we're going. So I am not, to maybe your dismay, I'm not going to spend a lot of times on these graphs that you'll see. This information was extracted from the Missouri Department of Insurance website, so I want to give credit to them for this. But these are real numbers based upon our performance as physicians and the insurance companies that provide us coverage. The things I'll point out on this slide in the top graph are, I would draw a line through 2005, which is where you see the peak of claims being filed and closed. You see a spike there. And if you recall, that's when the tort reform came in, and there was an absolute rush. And I think Diane can kind of back my thoughts here, that there was an absolute rush to file claims under the old guidelines before the new tort reform came in.
Yeah, most of your tort reform laws go into effect the end of August. It's usually like August 28th or so. And so we will see an influx of new filings that come in that week or so before, because the new rules would apply to any claim that is filed after that date. So there was usually big lines at the courthouse. I mean, now you can do it all electronically. You don't see people lining up on the courthouse steps like you used to, but we still see a spike every year whenever some new regs are coming out or new laws going into effect in August.
Right. And I think too, if you look at the 2 years trailing after that high point, you see a dramatic drop in the numbers of filings and closures on those claims, because again, this was a time where the new regulations were being felt out. We were seeing what the system was going to yield as far as the case moving forward or dismissal. And so you saw a significant drop off. And I think this is where we really saw plaintiffs' attorneys becoming significantly more selective in the cases that they were choosing to represent potential plaintiffs on. The other point I would point to, the other part of this graph that I would point to would be towards 2019 or so, where you see a trailing off completely, or not completely, but the low point of filings of lawsuits in the state of Missouri. So you see that the frequency is not as much of an issue as you might think, or some might lead you to believe. So next slide. I think what we see here is, and I apologize for the size of these graphs. This was a little bit hard to squeeze onto the slide template, so I'll just talk about it to a certain degree. Again, I point to, let's say 2005, 2006, where you see the average cost of, recovery by claimants was about $300,000 on average. Look forward to 2020, and you see that number is now $500,000. That's a significant jump in those 15 years, and that is reflected in some of the continuing slides I'm going to show in just a moment.
And I think one of the things we see from, handling medical malpractice cases, and it's kind of what Jeff said earlier, is, I think plaintiffs' lawyers are being a little bit more selective in the type of cases that they're choosing. They're not so quick to just file cases that may have questionable liability or don't have significant damages. So the cases that we're getting involved in and defending typically are more serious cases where there's bigger liability, and your settlements be bigger. And if they go to trial, your verdicts may be bigger if we don't get that defense verdict.
Exactly. Thank you. This slide just represents where the biggest frequency of claims are coming from, and I think this really gets into the severity of them. It's a trailing number, but I think you kind of see that.
Jeff, I'm sorry to interrupt. The slides aren't moving. They're not advancing.
I just sent you a text message about that.
Oh, can you see it now, or are you still on the first screen?
We're still on the first one.
Okay, we're gonna take a time out here.
Check your text message.
Okay, I'm gonna try to reshare.
So Diane is the one that's sharing.
Okay, I should be sharing. Can you see me scrolling through now?
We see history of malpractice in Missouri from 2005 to 2020.
Yeah, but it's not advancing now.
There we go.
There we go.
See that? All right. Were you here, Jeff?
It's working now.
Yeah.
Okay, thank you very much. Appreciate it. Gotta
Sure.
love technology.
I was actually more excited that I saw someone had a question.
A chat.
Dan, I can always count on you for a criticism. Thank you.
You're welcome.
So, as I was saying, I think this slide represents the more catastrophic outcomes that we've endured over those 15 years or so. It gets into the cerebral palsy, the paraplegia, the quadriplegia, and I guess most frequently neurological deficits. And you see the attributable average payment to those claims. So I guess in a snapshot, these are the catastrophics, and these are what they average when it comes to payment. So, okay, did that slide transition? What you see is company and
No. We're still on history of malpractice in Missouri from 2005 to
Are
2020.
you seeing me move to the 3 now?
Yes. Yes.
Is this where you want to be?
yeah.
Yeah, we're good.
Exactly. You know, I put this slide up just to kind of give a representation of who the carriers are in the state of Missouri. When we look at who are the big writers in the state, who has the majority of the market share, and I think it represents a lot of names that you all have had coverage through, currently have coverage with, and just overall what the market looks like as far as carriers go. So this slide, and this is where I wish I would have made the text bigger, to be honest with you. I'm going to put my own cheaters on. Okay, this kind of gets into this slide overall, gets into the overall performance of carriers when we look at them from a financial perspective. And what I'll talk about here is how it relates to premium written versus premium payouts, and kind of the return on that net worth, if you will. And really kind of what I wanted to illustrate here out of all this data is, let's look at 2016, you know, as an indicator of kind of where we are and why we are here now in 2022. If you see the return on net worth from the carriers and the business that they've written in the state, it definitively trails off in those last 6 years. And you see that they're at a zero net profitability and in a deficit in some cases. And you know, this data is affected by the progression of lawsuits, the reserves set for those lawsuits, and I guess the seasoning of the lawsuit itself. But you know, we definitely see that we went from double-digit net profitability to flat or loss.
So the carriers are not sitting there making tons of money off of all of these premiums.
Despite what we may all think. So I just transitioned the slide. I'm hoping you're seeing three charts. Okay.
Yeah.
What I want to concentrate on in this slide or this graph is the middle. We're here today talking about our physicians and surgeons. And I think what you're starting to see here is the severity, excuse me. The severity of the actual loss ratio of these carriers that are in the state of Missouri. Again, this relates to, I guess in simple terms, dollars collected in premium versus dollars spent defending claims and other costs related to the provision of medical professional liability. Again, we start to see this trend, if you look at it, creeping up really since 2013 with a significant bump there again in about 2018-19. And I think this is really where we see the cause for concern or a pause for concern from the carriers. And subsequently, I think a lot of our practice administrators can attest to, we're starting to see higher premiums over these last 2 to 3 years. So,
Unfortunately.
you know, and again, you'll see a dip at the end of that graph. Again, that's attributable to the seasoning or the progression of the actual claim itself. As the claim progresses through the legal process, the reserves placed towards the potential outcome of that case can either go up or go down, but I think you will see those go up as the discovery process progresses. So. And now I'm on a pie chart with multiple colors. And basically what this is illustrating to us is where are the malpractice payments going? And I think you see the two largest pieces here. Physicians and surgeons represent about 25% of the settlement dollars that are actually being distributed to patients for adverse outcome. You know, hospitals certainly take a bigger chunk of that, and you know, it would be my supposition that that's attributable to deeper pockets or you know, financial resources that are available through the hospital, you know, when it comes to these types of events. So I thought this was an interesting slide, and this kind of talks, you know, in a snapshot about how long it takes for a claim to progress through the legal system. And the two things that I circled for myself in my notes talked about 0 to 24 months. And you know, Diane, you might be a little more educated on this, but I would suppose in this case, this is where you see the largest part of dismissals or settlements or adjudication of the claim itself, just as we go through that discovery process. But then the bigger note I circled to myself was the 48 to 60, which is that highest bar indicator. And I think that it's a statistic I've known for years, but I think to the outside world, it just shows you how long that this process can take and the amount of legal resources that can be allocated to a claim.
If your doctors or you as an office manager have never been involved in defending a malpractice case, that's one of the very first things I sit down and talk with my doctors. I'm meeting with a doctor tomorrow. It's his first lawsuit, kind of going through things. And that's one of the eye-opening experiences, is for them to understand that this process is going to go on likely 4 to 5 years. You know, they have this vision from TV that, you know, cases get filed and they're going to trial in 2 weeks. And the process goes on a lot longer than that. I've got cases set for trial later this summer that are from care rendered back in 2016. So COVID has certainly delayed things a little bit more over these past 2 years. But I would say on average, maybe 3 to 5 years for the defense of a case.
And I wrote myself a note here, and again, this is not fact. I just offered as conversation that it was said to me that 9 out of claims that are filed are dismissed, and that 9 out of the 10 of those that move on end up with no settlement. So there's a, you know, I don't have data or facts to back it up, but you know, the overall opinion is that a lot of these cases wind up in a defendant's favor. So this might be disappointing, but this is actually going to be the last chart or graph that I have to talk about. So what I highlighted here for your review is, you know, where the cases, you know, indemnification by specialty, I guess the best way to say it. But you know, you see the dollars allotted and the actual claims outcomes for the various specialties that are out there. You know, and the ones I highlighted were orthopedics and emergency medicine. They're certainly towards the top of the charts. Internal medicine, I think, just based upon the sheer volume of patients that a internal medicine physician sees, the OBGYN cases that we talked about that can have significantly adverse outcome, as well as radiology and anesthesiology. So I guess one that kind of popped off the page to me and it caught me a little bit by surprise was pediatrics. And I don't know if that's a matter of, you know, an adverse outcome at birth and the pediatrician is named, or but that actually did jump off the page a little bit at me in the amount of dollars.
It's probably more pediatricians being involved at deliveries and hospital-based pediatricians as opposed to their office-based practice would be my guess. We see a lot of, there are indicators when a pediatrician has to be present at delivery as opposed to just the newborn nursery nurse being there to help, catch the baby type thing. And with there being more hospital-based practice of pediatricians, I would suspect that's where a lot of that exposure is coming from.
Makes sense, but like I said, it was a little bit of a surprise to me.
Sure.
Okay, enough with the charts and graphs. What I want to talk about, and I want to kind of summarize some of the things we've talked about at this point as we transition. Again, we go back to 2000, and as I was coming into this industry, we really had basically three choices in the standard or admitted market. What I mean by that, standard admitted market would be your traditional companies, your medical protective, your doctor's company, your Pro Assurance, your Norcal, PSIC, et cetera. At that time, MedPro, Intermed, and Pro Assurance were pretty much the three standard carriers that were writing business. As we move forward, 5 years later, I can think of 6 companies that were starting to write a significant portion of what we'll call the standard or admitted market. And I think this kind of coincides with the growth of the 383 mutual accessible companies that offered, certainly an option to physicians and rate relief as well as good coverage for their needs. Fast forward to 2020. I went back and looked at 19 carriers that had what I would consider a significant market share that, again, I would classify as admitted or standard carriers in this marketplace. That's great competition. As I go down to my bullet points, these are just the horror stories of that time. What I recall is most of your standard markets would not write physicians with claims. I can recall physicians having to purchase tail policy and start with the new carrier without any prior acts. It had to be on the tail with the old carriers because they didn't want to assume that legacy of exposure during those market conditions.
We do have a question from one of our radiology folks, Chris Keith, was asking about, it's probably on your prior graph, whether or not the radiology that was listed on there is mainly mammography related.
Chris, great question. I can drill down into that. I think it's certainly a good question worth asking. What I can respond with is what we're seeing, or the feedback we're getting from the carriers right now is diagnostic radiology is absolutely a hot spot in medical malpractice and the claims filing. It's a specialty that carriers have somewhat cooled on as far as their ability or their desire to offer competitive premiums on, and certainly with restrictions.
And I can add in too that I have probably 6 cases in the office right now that are failure to diagnose cancer. Whether it's mammography certainly is a big part of that, but we also get it with CT scans and diagnosing lung cancer, those types of things. So it is the classic, hindsight is 2020, and they're going back and looking at the radiologists who interpreted those scans, but also the primary care physicians, or if it's OBGYNs that are following up on clinical indicators for whether or not somebody has the picture of cancer. But definitely the radiologist, and like Jeff said, it ends up being a diagnostic type thing, but they're typically brought in on the cases I see with other defendants. It's just another pocket, another insurance policy in another pocket.
Thanks, guys. It's kind of scary.
Yeah, no kidding, but thank you for the question, Chris. And then again, I referenced this earlier, but this was real and true. I had clients that were paying $120,000 a year for, limits of 1 million, 3 million coverage in OBGYN. So, and I kind of transition here to a hardening market. What we're seeing is what I've talked about thus far. Claims increasing, not as much. that we're enduring right now, but we're certainly enduring rate increases. We have seen a contraction in the number of carriers that are available to us in Missouri. Not significant, but yet we are starting to see either mergers or have been seeing mergers, as well as insolvencies, carriers going out at this point and leaving the market, or just choosing not to renew the physicians that they have and moving out of the market. I think we remember St. Paul in the late 90s, early 2000s was a significant writer of business and made a decision to get out of the medical professional liability market, which created a lot of transition and transaction, And this is a statistic that scares me, quite honestly. And I think these numbers are somewhat rounded, but they're the numbers that we hear bandied about by our carrier partners and kind of our own, review of the agency's book of business. That, if we go back to 2008 or so, we had 70% independent physicians. Now we're looking at 30%, and 77% employed. That's a marketing change. So, I think here I want to talk just a little bit about, what are the byproducts of the hard market. I think we're seeing a reluctance on the carrier's part to buy market share or have rates that are unsustainable long-term for the exposure that they're undertaking. As we look back, right around 2018, 2019, when we, as an agency, started to see rates increasing, an activity or an action that we hadn't seen in many years. It was a downward trend on premiums, I think, as you'll all remember. But now, I would say for a good 3 years or so as a broker, I've presented increases. As always, this has a high impact in the rural areas. The revenues in some of the rural practices aren't strong, and those rates, need to be offset somehow. So we see the dynamic of docs are either retiring early because the expenses are getting too high and can't keep up with the technology investments, or they're selling their practices to the health systems. And then from the carrier side, we're seeing, in some cases where we're seeing a discontinuation of underwriting certain specialties. I've got carriers that are no longer writing OBGYN, and that hurts. We want the competition for our clientele. Orthopedics and neurosurgery, they're taking a hard look at those and looking at the claims that they may have experienced. Fortunately, we can definitely discuss the details, kind of look at the case itself and kind of determine that, this may be frivolous, or, this should end with a positive outcome for our client. But, the underwriters are looking a little closer at it. And then certainly bariatrics, as an older broker at this point, I can remember a time when very few, if any, carriers will underwrite bariatric surgery. Yeah. And the outcomes were not always positive. I've started to kind of enter back into that. I don't have a lot of bariatric business, but it is a little harder to place, especially when there are claims. So. Kind of want to get into, just kind of who's helping us, who's going to help us out. Then I'll start wrapping it up. I'm getting the wrap it up sign from Diane.
Let's talk about it.
I point to a couple of significant points in time. 2005 was the really impacting tort reform, passage. And I think we saw, the kind of a turnaround at that point for our clientele. 2015 and 2019 brought some positive adjustments to tort reform for us as a market. Unfortunately, bullet point number 2, we are being referred to right now, and have been for the last year or two, as a judicial hellhole. Not a title you want to hold, in the marketplace, but we do still have competition in the marketplace. Carriers are still interested in being here. We do have caps on non-economic damages. believe about $400,000 for non-catastrophic and $700,000 for catastrophic. And in my research, there is a cost of living increase applied to those numbers every year.
Yep.
So, and they've done away with venue shopping, where the service is provided is where the claim will be defended. Does storage help? Yes. More carrier options, fewer lawsuits, premium increases in dividends, and physician count growth. I mean, these are general statements, but these are the positive effects of what tort reform can do, and why we should all be advocates within, our community here to see that these changes in this assistance put forward. So, and then finally, I'm kind of getting into the wind down of where we're at. Again, 2004, we were in a bad place, but then 2004, 2005, we started to see new carriers into the marketplace. You saw premiums drop, you saw physician count rise because it was a more positive marketplace to come in and provide medicine. Good community, premiums were dropping as far as the context of what we do. 2007 and 2018, we saw numbers of carriers increase, premiums continuing to drop throughout that to almost somewhat historic lows, and definitely marketplace competition. I think we look at kind of 2019 as where the market begins to harden, and I underline and I stress frequency of severity here. Again, not so much the frequency of claims being filed, but the severity of the outcomes of these. Again, plaintiffs' attorneys are selecting cases to defend that they think there's going to be a more higher percentage of positive outcome for their clients. And subsequently, as we talked about in one of those previous graphs, you see the significant increase in the severity of payment, and that has to be paid for in our industry, and it usually trickles down to us. 2019, we saw carriers starting to exit the market, either insolvency or merger or other means of leaving the market, but these are not positive indicators. And again, I think as the practice administrators would probably attest to, 2022 is we're seeing a continuation of the double-digit increases, on premiums, and we are fighting as brokers, your broker, and the Keen Group, and everybody else representing you. We are fighting for those, but what the carriers have indicated is they need to get to a place of rate adequacy, and they need to correct those loss ratios that we discussed earlier. They're losing money on insuring physicians, and that's not a long-term strategy for them. In summary, the long-running soft market is over. The economy is not as much of an effect on the claims as it may have been in the past. Claims frequency is stable, but severity is definitely spiking, as we indicated. We are seeing annual premium increases. I know I would say the last 3 years, with the agency, we've seen it, but there are options. And these are real numbers. These are everyday numbers that I remember seeing in 2004, 2006, and kind of what we're seeing right now for an internal medicine doctor. And it shows kind of the reality of premiums and where they're at. Again, indicators of those are insurance companies slowing the pursuit of market share. You definitely want to have market share. You definitely want to grow your representation in the market. Again, these are some of the largest carriers that we have as an agency deal with, but in the marketplace in general. We're seeing mergers and consolidations of carriers. I think, a lot of you folks will know that ProAssurance and NorCal completed a merger last, I believe, March or April or so. And that took, I guess number 4, number 5, and made them number 3 as far as market share goes, or potentially arguably number 1. I don't know the actual numbers there, but again, you take two companies and make them one, and they got bigger. So We've talked about loss ratios and what they mean, but those are real numbers that we're seeing from some of the carriers that are in the marketplace right now. And again, your loss ratio, you definitely want under 100%. So you kind of see the severity of that. And honestly, you all have more to worry about than just your malpractice bill, you know, and these are some of those challenges. So what we see for the future, you know, in the analysts and the lawmakers, the talking heads, if you will, I think I personally feel the worst and the most impacting are over with at this point or have subsided. I think we'll continue to see gradual changes, but I think that I hope and I think that the hardest adjustments have come in the last few years now. Rates have definitely bottomed out, you know, and again, you can attest to the premium increases that you've seen. I don't really see a lot of urgency on new tort reform or adjustments to that. Diane might be able to speak a little bit more effectively to that. Competition is slowed in the marketplace. And again, we talk about lower premiums are no longer supporting the number of claims and the hard market has returned. So, and this is, I guess, more of a transitional slide for Diane, for me to hand the cursor over to Diane, but I think it affects both sides of the table here. So I'm going to switch places. I thank you for listening to me for the last 35 minutes or so, and I'll be in the background.
Jeff, we did have a question that they wanted to know, is the malpractice pressure easing in Illinois or is it still a high risk state?
This is a great question, and forgive me if I didn't talk much about Illinois. We represent a significant amount of physicians in the Illinois market as well. Excuse me. We're seeing similar over there, and unfortunately, the same $15,000 internal medicine physician that I talked about in Missouri is probably $22,000, $23,000 in Illinois. I know Cook County, which is to us St. Louis folks, that's Chicago, if you will. Cook County is really seeing significant increases, you know, and that's definitely a market where carriers have said we're willing to let the client go or let the insured go rather than try to chase premium, because we cannot support from an actuarial standpoint. We cannot support the premiums that have been charged in the past. There is also, I would mention, legislation that was passed last year in Illinois, and I don't have the actual statute, but there is an addition of a percentage of interest, I believe they refer to it as, for all claims that are filed, that starts at the date of, I believe, either service or date of filing, that interest will accrue on that reserve as a means of, I guess, cost of living.
Yeah, it's a prejudgment interest provision that when the lawsuit is filed, the meter starts ticking. And so when we talked about that 4 to 5 years to defend in the ongoing litigation process, that meter is running. So we have found ways to be able to make settlement offers early on in the case to try to be able to hedge the potential liability that may come out of that. But it is something that affects the length of the cases that are out there, and something else that takes a toll on it.
Definitely so. And from the carrier standpoint, it's money that they have to reserve.
Yep.
And the trickle down effect is, of course, what you would think it is, which has to be reflected in the premium. Now, that was Cook County. I know that in my experience over the years that Metro East, St. Clair County, Madison County, thank you, are a lot of times lumped into those same rating classifications.
Yep.
Not always the case, because different carriers have different experiences in markets, but there is somewhat of a similar consideration when it comes to Madison and St. Clair County as far as underwriting guidelines application and premiums subsequent to that. So.
And we see that in the value of the cases. A lot of your verdict values that come out of Cook County juries and what they'll award can be, you'll see a lot of that down here in St. Clair. Not so much in Madison, but St. Clair is still pretty plaintiff friendly. So,
You know, I guess to answer your question in summary, no, I do not see things getting better for Illinois, parallel to Missouri. It is a different market. So.
all right. Well, I thought I would kind of do a twist here on COVID a little bit and with telemarketing. And I know we're running only got a little bit of time here, so I'm going to probably try to keep this a little bit more high level. But, you know, I spent some time thinking about what is a good risk discussion to have with our physician practices and what you guys are facing. And it's easy for me to talk about lawsuits and what we've seen in the past, but I thought it'd be a little bit more interesting to talk a little bit about, you know, what's coming out of the pandemic as we hope to emerge out of this. What have the states been doing across the country to try to limit the liability from all of our healthcare heroes who have really been in the trenches trying to get us through this pandemic and provide medical care and working tremendous hours and exposing themselves. So we've got some good news that have come out of this, but I thought what I would try to do is give you some tips on how to really make sure you can take advantage of these things. So some stressors that I think a lot of practices have had is dealing with workforce and staffing and how COVID has impacted our ability to keep practices open, quite honestly. A lot of healthcare practices have really had the strain in trying to recruit and to bring people within their office and keeping them there. And you deal with a lot of burnout among healthcare providers due to this prolonged COVID-19 pandemic. If you had told me 2 years ago that we would still be dealing with this, you know, I would have lost that bet in Vegas big time. So one of the things that's important for you to try to do is to reduce the administrative burdens on your staff to allow them to focus more on patient care. That's why people go into medicine, whether it's physician or nursing, they want to provide patient care. So do what you can to try to reduce those administrative burdens. Try to implement workflows that allow patients to pre-register for appointments. One of the things that Jeff and I were talking about is so much during this whole pandemic and sheltering in place, people have had to rely so much more on technology. You're using your phones to do things. You're ordering groceries now online, you know, which was possibly available before the pandemic, but it's becoming so much more of everybody's daily lives to be able to use their computers and phones to do these types of things. So try to implement some of those workflow processes into your practice, whether it's allowing patients to pre-register online to update some of that demographic information, which is going to cut down on some of those burdens your staff may have. If you can allow administrative staff to do some work from home as opposed to always being physically present, that obviously can reduce stress and also potential exposures. Kind of coming out of the exposure thing with the extent of the vaccinations that's been happening, but just things to still keep in mind. Don't take your eye off focusing on those mitigation risk steps. Another recommendation I saw out there was identifying ways to group similar appointments together to reduce physicians and staff's burnout. So, I mean, if you can get similar types of appointments scheduled on Tuesdays versus having physicians jump from different types of practices and different types of appointments throughout the day. And then consider on-call schedules for staff in preparation for absences. I can only imagine what you office managers are going through in terms of staffing. I know many of the folks even on our board here with MGMA are often filling in and covering the desk or filling in the back office doing some billing because it ends up being all hands on deck. So I don't want to get too much into this, but staff vaccination status, you know, I get asked questions about whether or not you can mandate and require that folks get vaccinated and boosted. So back in November, there was the interim final rule that came out, and it was part of Medicare and Medicaid that was part of the Biden administration that mandated that all healthcare providers within hospitals, long-term care facilities, everything, it did not include physician practices, were mandating that healthcare providers be vaccinated by a certain date. There were challenges that were filed by several of the different states to try to challenge this to coming down as a federal mandate. And the Supreme Court ruled on this in January and upheld the vaccination mandate. Like I said, the law applies to hospitals, ambulatory surgery centers, dialysis facilities. You can see the list there, but it doesn't apply specifically to physician practices. So the question is, many physician practices have voluntarily established mandates for their employees. I'm not here to tell you whether or not you should or you shouldn't. These are just issues that you have to take into consideration. And it certainly is something to run past your employment counsel, but you've got to consider the unique situations within your practice. If you're going to force a vaccination mandate and you've got some of your employees who do not want to get vaccinated, whether or not it's a religious issue, it is just a freedom of choice issue, you know, are you going to risk losing those people? So something to really keep in mind and to think long and hard about your own individual practice. And then timeline for compliance. You know, you're going to require it now, or is it something that you can set up over, you know, that it needs to be within the next year or so? But whatever you choose to do, you need to make sure you clearly communicate that policy to all of your employees and the rights. And then you also have to consider whether or not you're going to have a rule in there that they can be terminated if they refuse to become vaccinated. Once again, it gets into a lot of sticky issues with regards to employment rules. So consult your employment counsel on it, but something to keep in mind. If employees contract COVID while at work, make sure you've got contact tracing. I think by this day and age, everybody pretty much is living the dream with all of this going on in contact tracing. You know, we hear it at our schools. I get emails every day about the exposures within the school, but, you know, make sure you don't forget about privacy, that you're not supposed to be disclosing the name of the person who tested positive. Make sure you're following your CDC guidelines on reopening the practice. If you have to close down, this has changed. So make sure you're checking with the local CDC guidelines as well as the county that your practice is located in. I think the current rule is they have to quarantine for 5 days and then they can return to work with PPE. So, you know, when we started this whole thing 2 years ago, it was you were out 14 days. And then there's changing rules of whether or not you have to have paid leave or not. So it changes pretty frequently, so make sure you're staying up on what the laws are with it. So making sure you're talking with all those folks. And then the other key provision I wanted to remind everybody about is if you do gather vaccination or screening results on employees, make sure you're keeping those in a separate location. You should not have any of their medical records within their personnel files to make sure you're maintaining confidentiality. I'll skip through this, but this is some of the guidance that comes down from the EEOC, and you've got the American with Disabilities Act issues that come into this about whether or not you're making accommodations for them if it's job related on sick leave issues. So make sure you're following that as well. Safety practices for staff. You know, communicate your safe practices, PPE, assign patient rooms, limited interaction, distance workspace, synchronized work schedules. I think we're doing a lot of these things already in the office. And out of the abundance of time, I'm going to skip through a few of these things and get into some of the other ones. Safety measures for patients. I'm assuming you've done a lot of these things too. Kind of going back to a point that brought up with Jeff is making sure that you're reviewing the coverage with your medical liability insurance carrier. Most of the research that I found, and at least from my conversations with Jeff, I think most of your insurance policies will cover claims related to patient exposure to COVID, or if your staff gets exposed to COVID and then contracts COVID while at work, you've got your workers' compensation claims, and your workers' compensation insurance should likely kick in for that. So it's really no different than a traditional negligence type claim. And I think it does come within the scope of your insurance coverage, but probably not a bad idea to have that conversation with your broker just to make sure.
You know, and I will add here that we've seen, I actually saw my first COVID referenced claim Monday in looking at a loss history for a provider. I think there's been very little, you know, brought to our attention. We're usually an intermediary when a claim comes in or a legal situation occurs with our clientele. So I've seen minimal to this point, but I guess very early on, I was part of a webinar where an attorney discussed and stressed gross negligence. The folks that aren't taking the safety precautions and requiring masks or are following some of those guidelines is close. So I think we're a little early in it, but
So here's the good news with regard to COVID. We do have a Missouri COVID immunity law. The majority of states across the nation have now implemented these. These are more recent from the Federal PrEP Act, which came out back in 2020. So most of the states have stepped up, and fortunately, Missouri's got a pretty good law for us. So what it defines is 3 different types of potential exposure. There's one for medical liability, products liability, and just general overall negligence. So a lot of the businesses pushed for protections from COVID liability for our folks that are doing their best to try to keep their medical practices open. This is the language from the statute, and I'm more than happy to have these slides available for you. You can look at the citation here to the chapter out of the Missouri statutes, but the key provision with this is that there is a rebuttable presumption that there is an assumption of the risk if somebody comes into your practice. But you need to be posting a warning sign in order to meet the provisions within this statute. I was doing some digging the other day, there are all kinds of vendors out there because, you know, where there's a need, there's a dollar. That will sell nice, pretty signs, but you can actually come up with your own. But this language is right out of the statute. And this is in essence, letting people know that if they enter your premise, they're assuming the risk of potential COVID exposure, except for recklessness or willfulness, wanton and willful misconduct. So that's what Jeff was talking about. This is applicable to any business within the state, not just specifically to healthcare providers. So I do recommend that you put some type of a warning posted in your waiting room that has this language out there. I'm going to skip through the other part of the language. The other part of this is with regard to for a plaintiff's attorney to be successful in these negligent exposure cases. In essence, they have to try to show that the healthcare practitioner or his practice engaged in reckless misconduct that caused the actual exposure to COVID. So you can imagine from a burden of proof standpoint, you know, how are they going to prove that a patient got COVID from your practice when they may have been at the grocery store or at Walgreens, you know, that same day, or their kids were at school and came home and brought it to them. So it can be a very difficult burden of proof from the plaintiff side of it, which is why I think we have not seen a tremendous influx of a lot of these cases. But I think the key part of all of this is making sure that you as a healthcare entity document all the different risk mitigation and protection steps that you have done in order to try to reduce that potential exposure, because it's a rebuttable presumption. So the burden's going to be on us as healthcare providers to rebut that, to say it's a very low likelihood that they contracted it from our office. And to the extent you have taken those steps and documented it, that's going to refute that willful misconduct. So the medical liability provision that applies out of the Missouri for healthcare providers, this is the language. You can only be liable for COVID exposures with recklessness or willful misconduct by a healthcare provider, and the alleged harm, damage, breach, or tort resulting in that personal injury was due to the alleged recklessness or willful misconduct. So all of those great actions you have to try to reduce the potential exposure to patients for contracting COVID out of your practice will help to break that causal connection. The other part of this that I thought I would point out, and to the extent we have some offices that are doing surgeries, we went through cycles over the past 2 years where elective surgeries were stopped by a lot of the hospitals. I think we're now back to doing the majority of those, but the key part out of this provision that I thought was interesting is that if an elective procedure is delayed, it's not going to be considered recklessness or willful misconduct. But I also always recommend that you document, so that if there is conversations with the patient to decide to put off that knee replacement surgery for a month or two, make sure there's good documentation in the record that you have discussed that with the patient, and that it was a risk-benefit analysis discussed with the patient, and they decided to agree with that delay and not take the risk of potential exposure. The other part of this is there also is a very shortened statute of limitation. So it's only within 1 year from discovery of the alleged harm caused by the healthcare providers Typically in Missouri, you have 2 years from the time of the harm to file a lawsuit, or 3 years from the time of the death. So this is only a 1-year time frame from the discovery, which I think is also going to help us not see a significant influx of these types of cases. So have robust policies and practices documented in place. Those are going to go a long way to developing these affirmative defenses to support your immunity. And it's also going to help to disprove that connection that they contracted COVID within your practice. We had a whole section on telemedicine, but it is 1 o'clock. So I'm probably going to go ahead and not necessarily jump into that. But one of the things that I wanted to just as a quick 60-second overview with regard to telemedicine, it kind of flows from the virtualization of everything that we're doing with our lives these days. Like I said, we're ordering groceries online. We're doing a lot of, Uber Eats and having things delivered, not just food, back to our houses to do these things. When we had this shelter in place, I think a lot of that was forced on us, but the way that we interact with different aspects of our lives has certainly changed. And telemedicine is something that the state of Missouri has been proactive on. We actually had telemedicine laws and provisions on the books for years, but I think as we emerge out of this pandemic, we are going to see a new norm with regard to how patients want to interact with their healthcare providers. And I think you're going to see telemedicine being incorporated so much more into how patients want to receive their healthcare provisions. So there are a lot of vendors out there that are tremendous resources to help you with the nuts and bolts and how to get set up with telemedicine. But a couple key things from a risk standpoint, and this comes from the lawyer, is the standard of care, whether or not you're providing a telemedicine visit versus an in-person visit, is the same. So your practitioners have to really think about screening who it is that they're going to allow to attend by telemedicine visits versus inpatient visits. When a patient comes into the office, your practitioner obviously can use all of their senses in evaluating that patient. Laying their hands on a patient or actually seeing it physically with their eyes in person versus over the camera provides a much different visualization to that provider than it may be over the telemedicine. But there are a lot of telemedicine visits, particularly follow-up visits with established patients that you've been seeing, where those are great for the provider. They're also great for the patient. So I think telemedicine is something that is here to stay, but you just got to make sure that there are certainly additional risks and liabilities that can come with that you really have to kind of put the forefront into thinking of that to try to reduce those things. And then one other quick point, and I know Jeff wants to jump in, is make sure you are talking to your insurance carrier about telemedicine, because there are rules and it's changed. The general rules always required that the physician had to be licensed in the state where the patient was located. So if you are a Missouri doc and not licensed in Illinois, you could not see patients that were in Illinois, even though those patients may have been driving across the river and coming to your office physically, and it wasn't a problem then. From a telemedicine standpoint, the rules that were in effect before the pandemic prohibited that. I will tell you, there has been some loosening of some of those statutes when we've been in a state of emergency, but we're likely emerging out of that here soon. So you need to make sure you're staying on top of that and talking with your insurance carrier, because you don't want to be practicing outside the scope of their license and not have coverage for those potential liabilities that could come out of that.
Diane makes a great point about that. As a broker, I would just encourage you to make sure that your broker and or your insurance carrier know the percentage of telemedicine that you're doing, that you've informed them of where you're doing it at. And they're probably going to ask questions or a one-page form for you to fill out that kind of outlines your safety precautions, your technology, and ask some of the questions that I talked about, just to make sure that they know the risk, that they're aware of the risk and where it's coming from. Not so much as a gotcha moment, but to make sure that they can cover it. Because, if as Diane spoke to, if the patient is coming out of Chicago to you, that's a different venue than Missouri is. They're coming out of New York, that's a very different venue and different rules that apply. So have that conversation with your broker and insurance carrier and make sure that what you were doing during COVID, which I know most of my clients contacted me about the telemedicine because it was the only way to keep the doors open at one point. Make sure that you've kind of updated that conversation to reflect more of a current scope of practice and how you're applying telemedicine.
And just one more litigation related aspect with regard to telemedicine. I haven't seen many cases, actually, I probably don't think I have any at this point with regard to a telemedicine provider having a lawsuit filed against him as a result of that. But I certainly think we will see that work its way through the court system. There usually is a lag to the reality and when it ends up in the court system. But my general take, and if you've heard me speak on liability and risk of lawsuits to physicians and practices in the past, has always been that patients don't like to sue doctors who they like and who they think are trying to do a good job. That bedside relationship with your patients, whether it's the physician talking to those patients, your MA, your office manager, your billing folks, all of that customer service skills and ability to relate and talk with patients and treat them as humans and make them feel that you generally care about them can go such a long way in mitigating the potential risks when something happens and something goes bad and the reason why patients sue. So as you are implementing telemedicine within your practice, don't lose sight of that. Make sure you have an opportunity to still establish that rapport with your patients. So have your time set aside for your MA to get on the phone with that patient prior to the doc coming in and, start that little chit chat conversation that they would typically do in the office. How is your day going today? Are you ready for the big massive snowstorm we have coming up on Thursday? Let them talk about their grandkids, that type of thing, so that they leave that telemedicine visit happy and feeling that, gosh, I really like that practice. I'm glad they're my doctors because, they're going to give referrals off to other folks. And that good feeling that they have from that experience can go a long way when something happens because things happen. So with that, we'll go ahead and turn things back over to Courtney to have her end it. Sorry, we ran a few minutes late, but I genuinely appreciate the opportunity to answer some of your questions and to talk with you guys. If you have any questions at all, I probably have it somewhere, but I'm not going to bother trying to scroll through.
We do have one question in the chat. It says it's regarding the keeping of employee records separate, and would a manila folder behind their personnel file or personal file, would it be the best, or how would you keep those all separate?
Yeah, you can do that. You just have to make sure your medical records are not part of an actual personnel file, so that if there ever is a request for an employee's personnel file, their confidential medical records are not being disclosed. So as long as they are pulled out separately so that they're not part of the overall general personnel file, that typically is good.
Okay.
So if there's any other questions you guys have, you'll find our email information on the website. I'm the Vice President of Business Partners, and Jeff has been my chair for years, but he keeps trying to get away. We're pulling him back in. So we'll see. But we're happy to have had the opportunity to speak with everybody and to go through some stuff and go forth and do good things.
Well, excellent. Well, this will conclude today's webinar. And I would like to thank everybody for attending, and a huge thank you to Diane and Jeff. It was a wonderful presentation. We also want to remind you of our May 11th webinar regarding top HR laws and regulations every organization should know. And you are able to register for that online at our website. So this will conclude the webinar, and I hope everybody has a great day. Thank you.
Thank you.
Thank you, everybody.